really see the healthcare for older adults in this country moving into the right direction. In fact, I hope by the end of this talk, I'll convince you that I actually think we're going the reverse. The statistics are getting worse, the mortality is getting worse, and I hope that this organization, that we take a little bit more aggressive role in saying enough is enough. We really need to start moving politics on aging because it's just not appropriate what's happening. It's not all bad news, right? So it'll be a little bit of positive news. But, well, I'm a clinician, I still see patients a little too much, maybe, but I figured let's do cases first, and then we'll base the entire conversation on cases. So case number one, Rudolph, 88-year-old gentleman who's very healthy. He's a former marathon runner, still runs, still moves a lot. He sort of describes his health as going to the doctors is bad, so I'm not going to do so, and if you suggest something for me, I'm not going to do it. I'm going to run away from all my healthcare problems. So here's your case number one. He does have some medical issues. You can see on the slide, he has glaucoma, he has some other problems. So, he's under your care, and you're going to have to think about how to talk to him. And then there's Lucas, who's been very healthy until his late 70s. He had a very successful business in greater DC area. But he started having this, typical aging arthritis of the knee, chronic pain, didn't go necessarily to his doctor, started taking increasing doses of ibuprofen, which followed by multiple cascade of different events. So this is a first of several slides of what happened to him. So you can see that first he started getting some swelling in his legs, he started getting acid reflux. We all know these are the typical side effects of NSAIDs or ibuprofen in this case, and that led to the follow-up problems. So how do we help Lucas, right? So they're two quite different gentlemen. We're going to have to look at them a little bit differently, but we're going to treat them both. So some of the questions that we're going to consider, as we get older, in a typical day, I may see a 75-year-old who looks like 95, and then the next patient I may see is a 95 who looks like 75, right? And yet we have to treat them we have to treat them equally in a sense of how we approach them. And of course, we're going to have to medically treat them completely differently. So bottom line though, we do have to look at each patient's beliefs. I went to talk that Josh Bed gave and other people today about, key question, what's important? And actually, when we get older, what's important for us may change. What's important for us when we're 50 may not be the same as when we get to 70s and 80s. And we sort of always presume that longevity and sort of absolute health is the most important things. Believe it or not always. There are frequent situations where attending a grandchild's wedding may be more important than even your own health. So sometimes we have to work in the constraints of understanding that, certain things are not achievable, which, by the way, it's also sort of this line between geriatrics and palliative care. At what point do you say, okay, I'm not going to anymore aggressively try to reverse something because that's not really the goal. It's not the goal for the patient, and it's not your goal because, trying to do that may cause more harm than any benefit. And that's sort of the unique challenge of geriatrics, kind of really super high touch, not necessarily high tech. And I think that's actually why I love doing sort of this holistic or integrative geriatrics, because it by default falls into the field of what we do. So remember bad news. Now there's a slide of several bad news. Now I want you to pay attention to the actual dates here. This is 2016, that's where the date ends. Do you see that dip in the United States of America? That's before the pandemic, way before, years before. Anybody, what do you think happened here? And this dip did not actually fully reverse. It continued for a little bit, it flattened out, and eventually I think it probably started to improve, but it's actually, look at the other countries though, like Japan, straight up, right? So we're sitting last in all developed countries in terms of life expectancy. What do you think happened there? Any thoughts?
Opioids.
Why?
Food.
Opioids is one contributor. Believe it or not, we were led to believe that's the main one. That's not true.
Growing inequality.
Food.
Growing inequality.
Growing inequality is a huge one, but I want you to be more specific. In what specific areas?
Top of the welfare.
it's specifically attributing to chronic care, chronic conditions. You know, we have a massive disparity, and our chronic care model is so broken that when you look at somebody who's a bit older and more frail, the difference there is much bigger. And actually, it's beginning to tank rapidly our longevity. And you'll see in the next couple of slides why. So, you can see this, right? Okay. So on the right, or on my right, I hope on your right too, that's us all the way on the right. So 42% of our population after 65 have 5 conditions or more, 5 chronic conditions or more. Look at the French, that's almost 3 times less. You know, they smoke, they drink, they do other things, and they're 3 times healthier. I don't know about that, why? But, you know, point being is this is what we're dealing with. This is why our, you know, longevity is tanking, it's not doing so great. Because we're managing these problems with medications. By the age of 65, 90% of the US population takes at least 1 pill, prescription pill. I'm not even talking about over-the-counter stuff. This is prescription medication. On the yellow, that third bar, that's 5 medications. 5 medications. So 40+% of the US population at 65 plus takes minimum, take at least 5 pills. Okay. So what do you think that's leading to? Or how does this look? Well, this is how it looks. So if you look at the Lucas, this is the cascade. He was pretty healthy, he had knee pain, he started taking 1 pill, pill caused swelling, pill caused acid reflux, he went to his primary care doctor, he got prescriptions for both problems. The omeprazole caused leaching out of some of the minerals, particularly magnesium. The edema caused him to get Lasix. Lasix caused some dehydration. Then he started having, as also part of ibuprofen, you can start having increased blood pressure. Hypertension is a very common side effect with NSAIDs. Then you're going to prescribe him another pill that now causing a cough. Now, of course, this is a made-up story specifically about the pills, but guess what? We see this every day. You know, when I'm in a Medicare-based practice, it's not unusual for me to have a new patient in the practice who comes in with 10 to 12 medications, and you look at this list and you're like, well, how did this happen? It's pretty obvious that there are 1 medication treating side effect of another one, and before long, you know, patient is on multiple medications, and unraveling this may take months, if not years, if it's possible at all, right? What happens, do you think, if we stop all of them at once? It's really hard to predict. Sometimes the patients crash, sometimes they do great, you know, and even if I do try to do so, imagine the amount of manual labor required to follow up each patient. We simply don't have that typically in the Medicare or Medicaid-based environment. If the patient has a lot of money, they can come to the Center for Integrative Medicine and get some care out of pocket for, say, knee pain with acupuncture. That can all be avoided completely, right? So now this is what actually happens in terms of statistics. So the polypharmacy, not necessarily correctly only, in combination. So there could be correctly prescribed medication, there's also could be incorrectly prescribed medication. So incorrectly often determined by, there's this idea of Beers-List criteria. Years ago, American Geriatrics Society created the list. Dr. Beers, I don't know, Beers, I don't think he was drinking beers, it's just his last name. So bottom line, it's no medications, and guess what? Let's go back to Lucas. So you see that at the bottom there's lorazepam. That's absolute no medication for geriatrics, right? Yet, at least 30% of all geriatric patients will end up on some kind of a medication from Beers-List criteria. Why? Well, because the providers who are trying their best don't have any other tools. They don't. They're going to prescribe what they've been taught. You know, if they've been through our fellowship with a little bit more of integrative medicine knowledge, they may do a little bit better. But we're talking about, there's a lot of older adults in this country, and there's a pretty massive shortage of geriatricians, and most of these patients end up being taken care of by regular internists, and often they really don't have tools. They're simply going to prescribe what they know. And so depending how you look at this, 3 million annual side effects, serious side effects from polypharmacy ends up being the 3rd or 4th cause of death among 65 plus. Look at the date. This is 2007. I did this on purpose. Because this data has been around for 15 plus years. You think anything changed? You think anybody's talking about this? No one. That's the part that infuriates me, because the data on all of this mess has been around forever. In our own fellowship, we kind of approach this, okay, teach fellows deprescribing, teach medical students deprescribing, teach residents deprescribing. Deprescribing is wonderful. Well, what are you going to do if the patient is still in pain? You're going to deprescribe all the pain treatment, and then what? So the problem with deprescribing goes only so far. It stops at the point where you're realizing I need to help this patient in front of me. And by the way, I'll be the first person to give somebody opioids if I have to. Because you facing with a patient behind a closed door, and quite often you have to treat them with the most effective tool you have, knowing that they simply can't afford. If I have a dual eligible Medicare, Medicaid, I'm not going to talk about acupuncture. Because they're not going to have funds to do it, and even if they have, well, if they have a knee pain, Medicare is not going to pay for it anyway. So, right, so the Lucas with knee pain was picked on purpose. If I picked back pain, you could have said, well, what about acupuncture? But for knee pain, he can't even get it, because it's not approved. So, in 2017, when the book came out, I wrote this definition, and actually I can't see it from here, so I have to I'm getting older, my eyes, I need new glasses, so you can read this. But the idea, of course, we're modeling the term after the consortium term, how it was defined back 10 plus years ago. But the reality is what my hope has always been, that the non-pharmacological tools come first, and even in the primary care settings. You know, and that's probably what truly differentiates, in my opinion, a good primary care from, you know, kind of a good integrative care, is that we would always think of non-pharmacological methods even before we think of pharmacological methods. So, and again, I started talking about the fact that as people get older, the difference in physiology, the difference in aging process, and the difference in multimorbidities and comorbidities changes. But we have to recognize it all, right? So we have to recognize and treat every culture and every background. Similarly, every life experience is important in itself. And actually, this is probably why I went into geriatrics. You know, my grandparents died when I was young, and I think I've always been longing to connect to older adults and learn and absorb this cultural and important differences, because I think that's how we get enriched, right? This is how we thrive. Remember I said about that geriatricians make less money than if they don't go through the fellowship, but they're also happier. They're actually the happiest healthcare providers. Somebody did that. Maybe somebody in this room did this study on it. But seriously, the geriatricians, we always joke that for geriatrics you have to have 3 qualities. Well, you know one, right? You don't have to care about the money because you're not going to make any. The second one, you have to have a lot of humor, because that's the best way to cope with often unfixable problems. Anybody want to guess the third one? It's really funny, the third one. You have to have a very bad sense of smell. So, well, we often take care of people who are really, really older and really, really frail, and I have several points to talk about the frailty. The idea is, again, your demeanor and your attitude and your ethos to everybody should be the same. You should really approach every soul in front of you with a sort of a deep gratitude that you allow to take care of them. So let's talk about specific clinical issues. The PPIs, I feel like proton pump inhibitors is one of my most hated medications. We'll talk about that. We're definitely going to talk about sleep. I think sleep is really a big deal. Again, notice that on purpose I could have picked all kinds of issues, but I picked things that the healthcare system doesn't manage really well. Right? And then, of course, the frailty and sarcopenia, and we'll talk about the difference between the two, is really the sort of the elephant in the room for a lot of people when they cross certain age, because that's naturally happens. In fact, the last decade of life, this happens to more than 50% of all of us, and knowing how to manage it and slow it down and prevent it to some degree is important. So, why PPIs are problematic? They're actually great drugs for short term. You get to the hospital, you have an ulcer, you got an PPI orally or intravenously, great. In 2 weeks you're better, in 4 weeks your ulcer hopefully healed, and then what? Well, Turns out in more than 30% of cases, you're still on that PPI 6 months later. Completely non-FDA approved and completely contraindicated in almost every case. Why this happens? You've all been to the hospital. You know what happens. The follow-up after the hospital is often spotty. Patient goes from one setting to another. They often go from the hospital to the rehab. And the rehab doctor may not even try to figure out why the medication was given in the first place. They're simply continuing it. So then, 6 weeks later, or whatever the length of rehab, the patient goes home, sees primary care doctor. Primary care doctor, well, I didn't prescribe this, so am I going to stop it? Again, same issue. So we're continuing this cascading, and then there is no thought. There's no thought often, not only because they're not trained to think about this, but guess what also? If I see a patient in a typical 15, 20-minute visit, patient has 10 medications, what do you think I'm going to have time for? Renew some of them, ask them how they're doing, and order some follow-up tests. And there's not enough time to go deeper into the list of issues. But long-term PPIs, this is a short list of problems. There's very controversial whether or not chronic PPI use causes Alzheimer's disease. And studies are controversial about this, and back and forth. I didn't include it because it's not evidenced fully. There's controversy, but nonetheless, it's a long list of problems. So how are we going to do this? How are you going to deprescribe PPI? You can't just stop it. If you just rapidly stop any anti-acid, you're going to have an acid flare for at least a week. Often patients feel awful. They may end up in the emergency room because they're going to feel so much acidity, going to feel a lot of abdominal pain, they won't be able to eat. Not a good process. So Vic-Sarpina, whom I didn't see this here.
No, he's not
So
here. He's
this is
probably-
Vic's work for the chapter in Integrative Geriatrics textbook. He came up with this sort of a protocol that I actually still use. Initiate the patients on a couple of different things. You can do aloe, you can do DGL, the licorice, you can do okra. You can do extracts, you can do some of it as a food. And the aloe you can literally just buy as a juice and drink it before each meal. So you're basically helping the lining of the stomach to line it with some substances that are decreasing effects of acidity on them, and then you gradually taper off the PPI. Sometimes I would use the histamines, ranitidine or something else, and sometimes you can even not do that. So you simply titrate slowly omeprazole to a lower dose, and then every other day, and then every third day, and then discontinue. So insomnia, well, why is it important? Well, again, there is no effective treatments. Every single hypnotic that's out there on the market is on Beer's list criteria. So theoretically, we shouldn't even prescribe it in the first place. Well, then what are the choices? Very effective is cognitive behavioral therapy for insomnia. Okay, has anyone seen the clinic that accepts Medicare for CBTI? See the hands? Yeah, I thought so. So we have a couple of providers in our DMV area and nobody takes Medicare. So, what's the point of covering something if nobody's going to take the insurance for it? It's very labor intensive. Frankly, we conducted a study, I think about 10 years ago, where we looked at mindfulness-based program based on Jim Gordon's work versus CBTI. Very similar result. Patients liked the mindful approach more. It was more patient-friendly for them. But MBSR is not covered by Medicare. Okay. So you can use some of the integrative modalities. We'll talk about this in a second. But the problem with insomnia is it's a contributor to lots of different problems, even higher mortality. So we know insomnia is awful. We know that actually over 20% of older adults will have a chronic insomnia and over 50% will have intermittent insomnia. And again, guess how this is managed? Right? Medications and more medications. So non-pharmacological methods, you all know. Acupuncture is great. You can try melatonin, in my opinion, it rarely works. Magnesium, every patient should probably be on magnesium. Sometimes it works really well. You can try other approaches, osteopathy and other things. Again, think of your typical Medicare patient on a limited budget of, say, $30,000 to $50,000. A lot of these modalities are completely out of scope for almost everybody, unless you're in an area that you just have a much higher percent of people with a high income. You're not going to be able to recommend this modality. Now, medical cannabis fits here very well. You do know that those of you who know me well know that this is my other passion, which I think I do use in clinic quite a lot, and I do think it's almost universal hypnotic exit strategy. So in my opinion, 80 to 90% of all older adults will respond. There's not a lot of really good studies. There are small studies in the younger population. And there's also a lot of observational data. You look at every state that have legalized cannabis, and use of OTCs for sleep and use of hypnotics plummets rapidly. Actually, it plummets potentially even more than opioids. I'm thinking it's because simply more people trying more effectively, because trying cannabis for insomnia is a little bit easier because it's very specific, right? You take it before you fall, you go to sleep, and if it works, great. And for chronic pain is a bit more heterogeneous. There's simply more variability in responses. So I typically start with very low dose, 1 to 3 milligrams of sublingual. Sometimes you switch after that to gummies. Tend to work great in very, very high percent of cases. And then you're capable of getting people off of hypnotics very quickly. If you tried before to get people off hypnotics, you know it may take, especially benzos, it may take up to 6 months or even more. It's very difficult. A lot of people who've been on them for a long time, they're so dependent on them that the rapid detoxification is basically impossible. You're going to have to switch them to other hypnotics. It's sort of like, it just doesn't make sense, right? So with Rudolph, we gave him very low dose tincture. He was quite resistant to it, but it wasn't a drug. So finally, his wife convinced him to take it. He did really well with this, and more importantly than that, his anxiety has also gotten better, and his blood pressure spikes, for which he took lisinopril, improved, right? So chances are he had a lot of anxiety-induced hypertension. Now anxiety is somewhat better. He doesn't need to take an extra pill. We see this all the time. Yeah, so if you try to collect the data, and I know that some of us in an audience, Rebecca is here in an audience, there is so much data that's already collected that's showing this exit strategy. In fact, I think Donald Abrams' husband wrote the whole book on this. Right? So you can use cannabis as an exit strategy, and here's an example that I think is evidence enough for me to present here today. So frailty and sarcopenia. So frailty is a critical concept. If you look at sort of the last 10 to 15 years of life, the frailty is what will determine the decline at the end. The acceleration of decline towards the last weeks of life is almost exclusively dictated by frailty. And it's actually a really important concept. We presume that mortality is closely associated with medications, with too many medications, too many medical problems. Turns out that the frailty is even more important. So what is frailty? In simple terms, the frailty is a lack of resiliency in the system. And it's not just your muscles, it could be your organs, it could be even your cognitive reserve, it could be all of it. And frailty in itself is not recognized as a medical problem. Now we have this debility NOS. I hate that diagnosis. It's like, what does that mean? Theoretically, there should be a code for frailty. The problem is if that's the only code you use, quite often nothing is covered. Like, good luck trying to order CBC for, well, CBC will probably gonna get covered. But any other more complex test, and the Medicare will refuse to pay for it. And that's kind of shameful because reality is, it's one of the most significant medical problems. If we only know how to deal with this, it would be important to be able to use it appropriately through insurances. It affects a lot of people even over 65. You see 10 to 15% will have it. And you all have seen patients like this, right? So they maybe only 65, but they don't move fast, they look fatigued, they look tired all the time, so that is a frailty. Sarcopenia, on the other hand, is a very specific term, only linked to the muscle strength. So sarcopenia is a specific term to muscle strength. And sarcopenia, I'm going to show you a lot of integrative methods because I do believe most of us should be implementing it in our practice, if not for ourselves. That also is really good, but also for our patients. So it's definitely a strength. So there's a scale, very simple scale, 0 to 2 for each one of those 5 points. 0 means you have no problems, so strength is a good strength, and 0, 2 would be kind of a poor or severe lack of strength, and so score of more than 4 would be considered sarcopenia. Now, that's not very precise. You also need to know how to use this scale quickly. So if you don't know, it'll probably take 5 minutes for you to get through this. So there's always been an idea, let's develop a much better test for sarcopenia, and actually they do exist. So we're in the middle of doing the assessment where you can take modified DEXA scan, very simple X-ray and low radiation X-ray, and looking whether that can be used as a screening tool. In fact, in the EU, they already have a pretty well organized process for diagnosing sarcopenia. In the US, if you go even to geriatrician, you're not going to get this test. The good geriatrician will do the SARC questionnaire, but again, it's not very precise. The test would be a lot better, especially if at some point it would be covered. So this is something in the workings, and once we have it, I think it'll improve our care quite a bit. So how can we help Rudolf and Lucas to prevent sarcopenia specifically and frailty? So, high protein diet, I think you all know this. Of course, vitamin D. Dr. Frame's probably pleased to see that. So vitamin D quite significantly, and this is really interesting because if you look at vitamin D studies in older adults, most of them are negative, except for one of these topics. So, if you have sarcopenia, you actually can slow down or even reverse it with a high supplementation, keeping the level higher. Assessing and addressing nutritional deficiencies, and definitely not enough time to talk about this. I do use quite a lot specific functional tests, and I love them. They're covered by Medicare across the board with no copays, so we use them a lot in our practice. And then of course managing polypharmacy, and of course physical therapy, and also the stimulation, neurostimulation, social stimulation. And then we have a number of integrative tools, right? So we have creatine now becoming a pretty much mainstream. Turns out it's quite safe. We used to be worried about renal function. Turns out it's not a problem whatsoever. We see a bump in creatinine, so we do see GFR drop, but it doesn't continue to drop. It drops a little bit and stays there. So pretty safe to give to everybody, almost. CoQ10, lion's mane, fatty acids. Urolithin A is a kind of the big one upcoming. I'm not going to tell you more about this, and I don't think from perspective of evidence, we only have a couple of randomized controlled trials showing some benefit, but I still think it's the one that will end up being more or less standardized. And then of course treating underlying conditions. If you have an inflammatory response, guess what? It's definitely going to increase the rate of muscle loss. There's no question about that. And then improving microbiome. I guess the improving microbiome is good for everything, but food-based, we don't have any specific probiotics data in that, I think. So key takeaways, unfortunately, most of our older adults are heavily over-medicated. I hope that our organization will have a say in that. We have the right tools. I think we have the right voice. I hope that we can move this field not only by the fact that we can prescribe better care, but also politically that we will move this. And lifestyles matter, no matter what the situation is. Even if somebody is in the last 6 months, you can still effectively utilize mind-body tools. Movement, by the way, even if in person on a hospice, will make them feel better. We often sort of presume that in the last months of life, you don't push lifestyle methods. That's not true. There's a lot of evidence for lifestyle methods making people feel better. And with that, in conclusions, if we did prescribe Lucas, he'll feel better, and Rudolf gotten better, and I think we can keep him healthy a lot longer. And there's this key concept: give life to years and years to life. And so we have to do both, not just one. And successful aging is far beyond being healthy and vibrant. It's rectifying internal conflicts, paradoxes, and redefining life's meaning, and adding years to life and life to years, as I said.